Welcome to the December 2024 LACNETS educational event. I'm Kavya Veligapudi, Executive Director of LACNETS.
I'm Lisa Yan, Director of Programs and Outreach for LACNETS.
And I'm Heather Davisi, Associate Director of Advocacy and Outreach for LACNETS.
Today's presentation is on Comprehensive Guide to Lung Neuroendocrine Cancers, from typical carcinoids to small cell lung cancer. A special thank you to our supporters Novartis, Ipsen, Crinetics, Curium, ITM, and Exelixis. LACNETS stands for Learn, Advocate, Connect Neuroendocrine Tumor Society. Our name also states the mission of our patient advocacy organization. The LACNETS staff includes Lisa Yen and Heather Davis. The board includes Donna Gavin, who is the sister of LACNETS founder Giovanna Joyce Mbezi, and NET patient Mary Dunleavy, who has been living and thriving with NET for 20 years. We're excited to share that LACNETS is partnering with the Carcinoid Cancer Foundation, or CCF, to provide support line assistance and other programs. For more information, visit lacnets.org/supportline. Now I'll hand it over to Heather.
Thank you, Kavya. Our YouTube channel features over 400 educational and wellness videos, testimonials, and podcasts. Use our playlist to find patient stories, information on types of PRRT, liver-directed therapies, chemo and immunotherapy, clinical trials, nutrition, imaging, and our annual conferences. And you can also find our videos by topic in our video library on the homepage, as well as our Learn tab. Follow LACNETS on social media. We are on Facebook, X, and Instagram with the handle @LACNETS. And be sure to add us to your Safe Sender email list. I'd like to remind the audience that LACNETS webinars are created for educational purposes only and do not substitute for medical advice. The views shared in this webinar are the experts' opinions. Please contact your medical team with questions or concerns about your individual care for treatment. And now I'll hand it back over to Lisa.
Thank you, Heather. I've been supporting my husband, who was diagnosed with advanced metastatic neuroendocrine cancer in 2015, and together we aim to stay informed and engaged with clinical trials as possible treatment options throughout our cancer journey. We understand that one of the challenges is not just finding the trial, but finding information about specific clinical trials relevant to us that is easy to understand. And this is why LACNETS created a clinical trials guide, which is an easy-to-use educational resource featuring several key clinical trials for neuroendocrine cancers. You can browse the site by the type of neuroendocrine cancer, such as lung, or types of treatments, such as immunotherapy. You can also find brief patient-friendly videos and information about each trial. And some of these trials Dr. Chauhan will likely discuss today. We hope that our clinical trials guide can help you better understand clinical trials that might be available for you. I'm now pleased to introduce our speaker for today, Dr. Aman Chauhan, a medical oncologist and neuroendocrine cancer expert who leads the University of Miami Neuroendocrine Cancer Program and co-leads the Sylvester Theranostics Drug Development Program. Prior to moving to Miami, Dr. Chauhan was at the University of Kentucky's Markey Cancer Center in Lexington, Kentucky. Dr. Chauhan earned his medical degree in India and then went on for a dual residency in internal medicine and pediatrics at Louisiana State University in New Orleans. He completed his fellowship in hematology and oncology at the University of Kentucky, especially focusing on neuroendocrine tumors. He also completed a special cancer therapy evaluation program physician externship at the National Cancer Institute that focuses on the design of clinical trials and clinical research projects. Dr. Chauhan is very active in both the clinical care of neuroendocrine cancers and in research. He only sees neuroendocrine cancer in his clinical practice, and he also sees a wide range of neuroendocrine cancers, including lung and high grade. On the research front, we know that Dr. Chauhan is a principal investigator on several key clinical trials, including those for lung and high grade as well. And he's authored multiple publications and book chapters and received a prestigious Cancer Development Award as well. Many of you already know Dr. Chauhan as someone who's passionate about helping patients, and he and I have had several discussions about how to better meet unmet needs in the neuroendocrine cancer community. We both share an interest to better support those affected by lung neuroendocrine cancer. So thank you, Dr. Chauhan, for joining us today to provide a comprehensive guide to lung neuroendocrine cancers, ranging from typical carcinoids to small cell lung cancer. Welcome, Dr. Chauhan.
Hello, everybody. Greetings from Miami. My name is Aman Chauhan. I'm a medical oncologist. I lead a neuroendocrine cancer program at Sylvester Comprehensive Cancer Center at University of Miami, and I also co-direct our Theranostics drug development program. Thank you, LACNETS, today for this opportunity to do a comprehensive overview of thoracic neuroendocrine cancers. Neuroendocrine cancers are rare diseases, as not one single disease, it's a bouquet of diseases, can happen anywhere in the body. But lung neuroendocrine cancers are one of the top three in terms of prevalence based on the sites. So this is definitely not an obscure disease within the neuroendocrine cancer realm. This is almost 20 to 30% of our patients. So very important to have a dedicated lecture on this important entity. However, as we go along, you would see that this is not a single entity in itself. Primarily, there are different types of neuroendocrine cancers, of NETs of lung, neuroendocrine carcinomas lung. So for the ease of viewership, we have divided this lecture into two parts. The first segment will focus on thoracic neuroendocrine tumors. These are relatively slow-growing type of tumors. The latter half of the lecture will focus on high-grade, poorly differentiated neuroendocrine carcinomas like small cell lung cancer and large cell neuroendocrine carcinomas. With that, I'd like to proceed. The key learning objectives, as I mentioned, we're going to understand different subsets of lung neuroendocrine neoplasms, and then, more importantly, learn about some new breakthroughs in management, how we treat thoracic neuroendocrine neoplasms. This slide showcases the spectrum of neuroendocrine cancers. On the top, you see neuroendocrine cancers can be divided based on their grade and morphology between grade 1, grade 2, grade 3, well-differentiated neuroendocrine tumor, and on the more aggressive end of spectrum, poorly differentiated neuroendocrine carcinoma. Very akin to that, in the lung world, in the middle of the slide, you will notice there is a similar sort of spectrum of neuroendocrine cancers. However, they're named slightly differently. Typical carcinoid, atypical carcinoid, and on the higher end, more aggressive end of the spectrum, large cell neuroendocrine carcinoma and small cell neuroendocrine carcinomas. So broadly speaking, we can group the whole spectrum into two major categories: NETs, neuroendocrine tumors, otherwise also known as well-differentiated neuroendocrine tumors, and poorly differentiated neuroendocrine carcinomas, or NECs. Putting a recognizable name to the disease so that you can relate to it. We have all heard of Steve Jobs, the inventor of iPhone. We unfortunately lost him to pancreatic neuroendocrine tumor. And on the other end of spectrum, Irfan Khan, prolific actor, who unfortunately succumbed to neuroendocrine carcinomas. So these illnesses can afflict rich or poor, young or old, and they don't differentiate. And today we will be focusing on the thoracic neuroendocrine cancers. Moving forward, how do we classify lung neuroendocrine cancers? Now, based on the WHO classification, there are four major categories: typical carcinoid, atypical carcinoid, they are both considered well-differentiated neuroendocrine tumors, and large cell and small cell neuroendocrine carcinoma or lung cancers, they're both considered poorly differentiated neuroendocrine carcinomas. And then there's a fifth category, which is a mixture of different subsets of those. And these are called mixed neuroendocrine, non-neuroendocrine neoplasms. And there could be a mixture of both small cell or large cell component along with non-small cell component like adenocarcinoma. For today's purposes, we'll be focusing on pure neuroendocrine neoplasms like typical, atypical, large cell and small cell neuroendocrine carcinomas. And how do we differentiate that? That's where our pathology colleagues comes in. They are probably the most important piece of the whole puzzle. And without their help and accurate diagnosis, we will be basically getting the diagnosis wrong, do the wrong type of diagnostics, tests, scans, and then of course the management will completely wrong. So many times these unsung heroes of medicine, the pathologists, they do the most important work is defining the diagnosis and making sure we get the disease correct. How do they do it? They take the tumor tissue, which we obtain with help of a biopsy, look it directly under the microscope with their naked eyes. And with the help of certain stains and dyes like Ki67, synaptophysin, chromogranin, they are able to differentiate whether this is a cancer or not a cancer. Within the cancer, is this a neuroendocrine cancer or a different type of cancer? Within neuroendocrine cancer is a well-differentiated neuroendocrine tumor like typical atypical carcinoid or a poorly differentiated neuroendocrine carcinoma. So this is all of this magic goes behind the scene with the help of pathologists. These are some of the examples in this slide. I'm showcasing how a small cell neuroendocrine carcinoma would look like. And in the center, you see the Ki67 with a small cell and large cell, very high Ki67, maybe 70, 80, 90%, and a lot of necrosis and those telltale signs of that this is a NEC and not an NET. Now, let's look at the distribution of these cancers. When we talk about lung cancers and divide them into a pie chart, about 20% of all lung cancers are of neuroendocrine origin, and vast majority of that 20% is small cell lung cancer. Roughly 14 to 15% of all lung cancers of small cell lung cancer. And there's a big difference in the incidence of that based on there are certain areas within the US which are hotspots for small cell lung cancer. East and West Coast sees less of small cell lung cancer. Appalachia region sees a lot more, and it is linked quite directly to the use of tobacco and smoking prevalence. As compared to that, the other rarer subgroups of neuroendocrine cancers of lung, the carcinoid, atypical carcinoid, and large cell neuroendocrine cancers of lung are rather rare, forming about 2 to 5% of all thoracic neuroendocrine neoplasms. And there is no clear correlation, especially with the typical atypical carcinoid, in terms of link with any environmental factors as of now. So for this talk, we are going to first discuss the lung NETs, and those are the top two categories, the typical carcinoid and atypical carcinoid. And later half of the talk, we will focus on lung NECs, the large cell neuroendocrine carcinoma of lung and small cell neuroendocrine carcinoma of the lung. Let's start with typical and atypical carcinoid. Now, between the two, typical and atypical, typical carcinoid by far are commoner between the two of these, almost 10:1. So if I have 10 patients with thoracic NETs, well-differentiated neuroendocrine, almost 9 of those 10 would be typical carcinoid. Median age around 50 years old. And the usual presentation, asymptomatic. They're oftentimes diagnosed incidentally, go to ER or get a scan for something else, and somebody spots a nodule in the lung, and that's how they're diagnosed. But sometimes patients can have symptoms like coughing, wheezing, even Cushing's syndrome, and certain other hormonal syndromes. And they can get underdiagnosed for several years before somebody figures it out and then finds this underlying neuroendocrine tumor in the lung. For some of the other characteristics of the typical carcinoids, as I mentioned before, they form primarily most neuroendocrine cancers, well-differentiated neuroendocrine cancers of lung, almost 90% of them, and the other 10% are atypical. Most of them, fortunately, are caught early. So they don't really have an opportunity to spread to the local lymph node or distant metastases. In fact, distant metastatic disease at time of presentation is seen in fraction of patients. Some reports only 3 to 5% of patients are metastatic at presentation, which is great news. However, some patients, about 15%, can be node positive at time of presentation. Still, largely majority of patients would still have local disease in the lung parenchyma and had not had opportunities, which is great. How do we diagnose these? Unfortunately, we don't have any good, reliable blood-based biomarkers. Sometimes we do chromogranin. However, It is not very accurate and has a poor sensitivity and specificity. We don't routinely recommend use of chromogranin to diagnose or monitor the disease. But in certain select situation, if patient has a paraneoplastic syndrome or a hormone syndrome, rarely patient with lung carcinoid might have carcinoid syndrome with elevated serotonin. So if you have a particular hormone and hormone related syndrome, then that particular hormone can be monitored and it's pretty accurate in terms of monitoring the disease. But there's no reliable blood-based biomarker that is accurate for diagnosis. So diagnosis is only dependent on biopsy proven histopathological confirmation. So you really need to get the tissue, have the tissue reviewed by an expert pathologist and get it accurate. Now, there are certain blood-based biomarkers that are under investigation. One of them, we are looking ourselves and trying to validate this in clinical trials. We stumbled upon HPG80, also called as progastrin, a few years back and tested in various types of neuroendocrine neoplasms. And we found that it is linked with neuroendocrine cancers, regardless of the type of neuroendocrine cancers, low grade or high grade, and regardless of the site of the origin. So we did find that it's elevated in lung or thoracic neuroendocrine cancers. We published our findings in Cancers a few years back, and currently we are testing this biomarker in multi-center clinical trials, and hopefully we can validate this, and then we might have a blood-based biomarker that we can use to reliably monitor the disease. However, so far to date, imaging is the gold standard to monitor the disease. One of the unique imaging, however, besides our routine CT scans, is a PET scan called dotatate PET. Neuroendocrine tumors, especially the well-differentiated neuroendocrine tumors like typical atypical carcinoids, can express somatostatin receptors. And we have really leveraged this property of neuroendocrine tumors to use for both diagnostics in terms of imaging and then later on therapeutics, which we'll discuss in a bit. So in this particular scan, the gallium-68 dotatate scan you see on the right side of your screen, we inject a dye that attaches to somatostatin receptors, which are present on the neuroendocrine tumors. If they are present on neuroendocrine tumors, this dye would attach to them and it'll release a radiation, which will then be captured on the scanner. For example, in this patient here, you see all these dark spots, the black spots you see, those are somatostatin receptor positive tumor. Previously, we used to use a scan called octreoscan, very similar concept. However, the resolution of scan was extremely poor. So the current dotatate PET scans are almost 95 to 97% sensitive and specific in picking up somatostatin receptor positive tumor. The tricky aspect is that thoracic neuroendocrine neoplasm sometimes can have low somatostatin receptor expression or no somatostatin receptor expression. So you do have to take it with a grain of salt, but you are going to be able to pick many neuroendocrine tumor of lung with the help of somatostatin receptor targeting. And this also has therapeutic implications because if the patient does have somatostatin receptor positive disease, that opens up some doors for some somatostatin receptor targeted treatments, which we will discuss in a few minutes. Now, why is it important to first confirm the diagnosis? Of course, because typical and atypical carcinoid have favorable prognosis. And then after establishing the pathological diagnosis, to stage the cancer based on imaging, the stage will be dictate to treatment. So if it's an early stage, that means the tumor is just located in lung or perhaps maybe to regional lymph nodes, but hasn't spread anything beyond. These patients would have great outcome with just surgery alone. Surgery itself would be curative in majority of cases. And the bottom of the screen, you see the survival outcome for these patients and patients who had early stage disease and had really good outcome with just surgery. So surgery can be curative in large majority of patients. Also for these tumors, because of the slow growing nature and lower risk of these tumors metastasizing early, the goal for the treatment with the surgery is to preserve as much normal lung as possible to improve quality of life, at the same time trying to get all the tumor out. Now, a few words about atypical carcinoids. Between the two well-differentiated neuroendocrine tumors of lung, the atypical carcinoids are rather rare. only 10% of well-defined neuroendocrine tumor of lung are atypical carcinoid. However, they are a shade more aggressive than typical carcinoids. At the time of presentation itself, they'll have a higher chances of being metastasized to the regional lymph node, unlike typical carcinoid where only 15% were positive at time of presentation. And these atypical carcinoid also has a much higher risk of being present in distant metastatic lesion or distant organ. So very important to have a thorough staging and confirm that there is not a metastatic presentation at time of diagnosis. So clearly, much more aggressive disease. As you can see here in the survival curve, the atypical carcinoid curves are substantially worse as compared to the typical carcinoid, which is the top line. So atypical carcinoid does confer somewhat poorer prognosis as compared to typical carcinoid. These patients metastasize, could metastasize, and then the median survival is not as long as the typical carcinoid. However, as compared to the poorly differentiated neuroendocrine carcinoma, the NECs, you see the bottom two lines here, the prognosis is still much favorable. So these are truly the middle of the road tumors. And I tell my patients when I see atypical lung carcinoid, you have to watch them very closely because sometimes they behave like typical carcinoids, so slow growing. Sometimes they can really switch the gear and act more like high-grade small cell or large cell neuroendocrine carcinoma. So we really have to understand the individual patient biology for atypical carcinoid and be ready if they switch gears and start acting more aggressively. Atypical carcinoid, unlike the typical carcinoid, also tend to have a little bit different mutational profile. It's not unusual to see more aggressive mutations like TP53 mutations in the atypical carcinoid. Again, however, we haven't really found a key driver mutation or something that we can consistently target for atypical carcinoid. So role of genetic testing is still under investigation when it comes to atypical or for that matter, typical carcinoid. How do we treat these cases? The principles of treatment for atypical, although it is a little bit more aggressive than typical, are still very similar to typical carcinoid. So if we find the disease early enough and it hasn't spread to other organs, the treatment of choice is resection, and surgery can treat and cure many patients. The goal of surgery is to preserve as much normal lung parenchyma as possible so that patients don't have terrible quality of life, dyspnea, shortness of breath after the surgery. But it's also important to surveil these patients more frequently because these atypical lung carcinoma patients have a high risk of relapse. We also know from long-term outcomes databases that those patients who have lymph node positive disease at time of presentation, they have poorer prognosis. However, we don't know if patients who have lymph node involvement, should they get more chemotherapy after the surgery, or can they be watched closely for any recurrence? Those are the things that are yet to be understood, and we don't have high quality data to justify adjuvant treatment. That means after the surgery, role of chemotherapy to take out any microscopic residual disease. So those are things that are not fully understood at this point in time. For metastatic, well-defined neuroendocrine tumors like typical and atypical carcinoid, we often fall back on a lot of our neuroendocrine tumor treatments from our GI world. In this slide, you're seeing the progress we have made over the years in terms of metastatic, well-defined neuroendocrine tumors, largely gastroenteropancreatic neuroendocrine tumors. But some of these treatment advances has extrapolated to thoracic world, and we often are able to use some of these treatments. So next segment, we will discuss management options for metastatic cancers. There are four main categories of treatment when it comes to metastatic typical atypical carcinoid, and those are somatostatin analogs, targeted therapies, chemotherapies, and last but not the least, PRRT or peptide receptor radionuclide therapies. Let's start with somatostatin analogs. Now, these are really important treatments and forms the backbone of the treatment. Somatostatin analogs primarily works on somatostatin receptor 2 and 5, which are very prevalent in well-differentiated neuroendocrine tumors. However, unlike your GI neuroendocrine tumors, which are essentially 90-95% positive for these receptors, lung neuroendocrine tumors might not be positive for receptors. So it's important to check for the receptor positivity with the help of dotatate PET before starting patients on somatostatin analogs. Again, large majority of neuroendocrine tumors of lung, the typical atypical carcinoid, will have some degree of somatostatin receptor expression, and that will qualify them for somatostatin analog. We currently have two agents, the long-acting somatostatin analogs, that are currently available in the US for the use in neuroendocrine tumor patients. One is sandostatin, other one is lanreotide. Both have been tested in phase 3 studies. Sandostatin was tested in PROMID study and found to be effective in neuroendocrine tumors, followed by LACNETS study that again tested lanreotide in neuroendocrine tumor patients and confirmed its effectiveness. So we have two options available. However, a dedicated lung net study is unfortunately missing. There was a trial, international study called SPINET, that wanted to test effectiveness of lanreotide in lung nets. However, was shut down early because of poor accruals. Again, these are rare cancers, very difficult to test new drugs because of rarity of disease. So unfortunately, we don't have prospective randomized data on use of SSA specifically for lung nets, but we do know that the disease behaves very similarly to its counterpart in the GI world. So the use of SSA is recommended by all consensus guidelines for metastatic disease, especially if the tumor are positive for somatostatin receptors. Moving on to the next big class of treatment called targeted therapies. For the longest time, we had no target therapies. Then in last decade, we learned that one of the pathways that are upregulated or active in neuroendocrine tumors called mTOR pathway leads to its rapid growth, development, and metastases. There is a drug that targets the mTOR pathway, and the drug's called everolimus. That this drug is not only used in neuroendocrine tumors, but also used in some select cases in breast cancer. So this drug was first incorporated in treatment of neuroendocrine tumors, especially for pancreatic NETs. But later on, there was a large international randomized control study that tested everolimus, the mTOR inhibitor, in all NETs, including lung NETs. And the study is called RADIANT-4. The lead investigator, Dr. Yao, published these data a few years back. And what you see here on the study key results, the patients who got the everolimus, their disease was stable for almost 11 months as compared to only 3.9 months in the placebo arm. So the drug is definitely effective, and this RADIANT-4 study led to its FDA approval for all neuroendocrine tumors, including the lung NETs. As mentioned before, many prior studies had left out this rarer lung net population. So it was a welcome addition to our armamentarium because we didn't have very many treatment options when it comes to lung nets. So, and the other unique thing about everolimus is the use of everolimus as lung net is not really incumbent on somatostatin receptor expression. So this is a good drug to fall back on regardless whether the tumors are expressing somatostatin receptors or not. Also, we do not have a good validated biomarker. So checking for alterations in PIK3, ATK, and mTOR pathway is not the right way to choose this class of drug. It works regardless whether the patient express alterations in this pathway or not. So we don't really have a predictive biomarker. So all patients with lung nets can potentially qualify for mTOR inhibitor like everolimus at some point in their course. And earlier this year, we had another breakthrough in terms of targeted therapies, and that drug is called cabozantinib. Dr. Jennifer Chen presented these data, and now it's in public domain, published in New England Journal of Medicine very recently. So what is this trial, the CABINET study? This is a trial. It was a large multi-center study that tested a drug called cabozantinib. It's a pill form of VEGF TKI. It's a targeted therapy that attacks the pathway that allows new blood vessel formation in the tumor, which allows them to grow, thrive, and metastasize. So by targeting that pathway, it slows down the growth of the tumor. This pill was tested in patients who had pancreatic neuroendocrine tumor and neuroendocrine tumor outside pancreas, including lung. The patient either got cabozantinib pill or they got placebo. This is a slide which shows the patient demographics. And as you can see here, almost 20% of patients in cabozantinib arm were of lung origin. A great step by the study team by including lung NET patients, because oftentimes they're left out of drug development. So it was good to see that the large patient population from belonging to thoracic neuroendocrine neoplasms were accommodated in CABINET study. So let's jump on to what type of results we saw. I'll focus primarily on extrapancreatic cohort. This cohort included a large percentage of lung NETs patients. As you can see here, patients who got cabozantinib in the blue line, the median PFS was 8.3 months as compared to 3.2 months in the control arm of the placebo arm. So drug is definitely active and is able to help stabilize the cancer in majority of patients. So very welcome step, and we now have additional treatment options. As of this talk, it's not FDA approved for the use in metastatic neuroendocrine tumor in the US, but the data is very provocative, and the drug is currently available for other cancers in the market. I routinely use the appropriate patient as long as I have access to the drug and as long as the insurance would approve it. So again, great addition for our neuroendocrine tumor patients. The next class of drug that we discuss is chemotherapies. And there is a role of chemotherapy, especially for atypical or more aggressive variety of neuroendocrine tumors. As mentioned previously, atypical carcinoids sometimes can behave more aggressively. They can spread. It's not unusual to see liver mets, even brain mets in atypical carcinoid, which are extremely rare with typical carcinoids. So since these atypical carcinoids are sometimes fast growing, they're also very susceptible to DNA damaging agents and classic cytotoxic chemotherapies. The treatments that are currently in use and guideline recommended include platinum-based chemotherapies, cisplatin etoposide, carboplatin etoposide, or pill-based regimen called capecitabine temozolomide, truncated for CAPTEM. So these are some of the options that we often use for metastatic patients who have rapidly growing disease, rapid doubling time, and are acting more aggressively. And one of the benefits for chemotherapy-based approach is rapid onset of action, and it is able to stabilize the rapidly advancing cancer rather sooner. Last but not the least, radionuclide-based therapies. So these are really tailored way of giving radiation. The traditional radiation is given by big machines, pointing a beam of ionizing radiation towards tumor, but it is not feasible to radiate all the tumors, especially in widely metastatic disease, without causing too much collateral damage to normal tissue. So Theranostics was born with an intention to radiate all the disease and bypassing normal tissue. So these are the class of drugs which are basically radioactive medicines. The two important components of this medicine, one is the targeting peptide. It's designated by the blue here in the illustration. So for example, in neuroendocrine tumor, as I mentioned, we have somatostatin receptors. Think of the receptor on the tumor like a lock. We have a key, which is somatostatin analog. This key likes to go and join the lock. So when we inject this drug, it will find wherever the lock is, wherever the receptor is, and this somatostatin analog will go and bind to it. Now, what we have done here with this theranostic drug is that we have linked the key somatostatin analog to a radionuclide. So the radionuclide is a heavy metal which emits ionizing radiation. So when we inject this drug, the somatostatin analog is trying to look for the tumors and attach this to somatostatin receptors. But once it attaches to it, it is attached to the radionuclide. So it is bringing the radioactivity along with it. And once it's in the tumor, it radiates the tumor and it causes the DNA damage to the tumor and kills the tumor cells. So that's how it's a very smart way of delivering radiation to specifically the tumors, because only tumors are expressing those targets. And this way we bypass toxicity to normal organs. The key drug here, which is relevant for our talk, is lutetium-177 dotatate, or otherwise also called Lutathera. This drug was first tested in neuroendocrine tumor of small bowel, a midgut neuroendocrine tumor, because they express somatostatin receptors. As you can see here in the Kaplan-Meier curve, patients who got Lutathera, the green line, their cancer was stable for a very long period of time. We now have long-term follow-up data from this NETR1 study. We know the tumors are stable for roughly 28, 29 months, as compared to control arm, which was just 8.5 months on higher dose octreotide. So this class of drug, the PRRT, is very effective in controlling the progressing cancer, as long as they have somatostatin receptors. And majority of lung neuroendocrine tumors, the typical carcinoid especially, will have somatostatin receptors, so it's a great treatment options for them. Based on this NETR1 study, FDA granted approval for use of PRRT with Lutathera in the US. I remember previously we used to send patients to Europe or other countries to get this drug. So now this drug's been available in the US for several years, and we use it. However, when the NETR1 was done, it was done specifically for GI neuroendocrine tumors. So the prospective randomized data for lung neuroendocrine tumors is missing, but we have data from Europe. Several patients have been treated for lung NETs, and it seems to work in lung NETs. And it's not surprising, as long as the patient has the target, it will work in a very similar manner. However, we still have to prove based on a prospective data. And to fill that data gap, some of our colleagues in neuroendocrine tumor world, Dr. Pada and Dr. Hope, they're leading a large multi-center randomized trial where lung NET patients will be either randomized to PRRT with Lutathera versus standard of care everolimus. And this study will definitely confirm the benefit or lack of benefit of PRRT in lung NET patients. It's a very important study. There are other novel form of PRRT also being investigated. For example, alpha PRRT, that's a newer type of radiopharmaceutical which emits alpha ionizing radiation. Here, the agent is called lead-212 dotamtate. Early data was presented a few years back in conferences. You can see this is one of the metastatic lung NET patients with great response. Again, these agents are under development. There are other types of alpha PRT under development as well. So it'll be very interesting to see how the field of radiopharmaceutical evolves in the lung NET space. We ourselves did a small study looking at the conventional PRRT combining novel radiopharmaceuticals. We used a drug called M3814, which is a DNA PK inhibitor, in neuroendocrine tumor models, and found that it is very effective as a radiation sensitizer. And then later we conducted a multi-center clinical trial testing PRRT Lutathera with piposertib, and all patients with neuroendocrine tumors who were allowed, including lung NET patients. This trial is now completed accrual, and we will hopefully read out the final results in next several months. That's my team at Sylvester. I think this is when we had concluded the final patient on the expansion cohort. All right, so last but not the least, one of the rarer subset of lung NETs, the metastatic well-differentiated neuroendocrine tumor, typical atypical carcinoid, can sometimes secrete a hormone called serotonin. This is usually not an issue in lung NETs. You've probably heard of a syndrome called carcinoid syndrome. It's a symptom complex of high serotonin along with flushing, wheezing, diarrhea, fatigue, muscle aches, etc. Very typically seen in well-differentiated neuroendocrine tumor of GI origin, the midgut with liver mets. But a small fraction of lung NET patients can secrete high serotonin and give rise to this carcinoid syndrome. So it's important to be aware of this syndrome. And we have a drug that targets specifically within the neuroendocrine tumor cells an enzyme, tryptophan hydroxylase, that manufactures this hormone serotonin. So this drug called tellitrostat ethyl, or Zermelo, is designed to block this enzyme to reduce the production of serotonin within neuroendocrine tumor cells, effectively helping with carcinoid syndrome diarrhea. So this is a drug that was tested in carcinoid syndromes, primarily of GI origin. And as you can see, is a name of study called TELLISTAR. And the study showed that this drug called tellitrostat ethyl, or Zermelo, was effectively able to reduce urinary 5-HI, which is a breakdown product of serotonin, as compared to placebo arm where there was no effect. Currently, the drug is available for carcinoid syndrome diarrhea refractive to somatostatin analog like sandostatin or lanreotide. So something important to be aware of, that there are other agents that can help with this hormone functional syndrome in certain subset of NET patient. Earlier this month, I also presented some data from another type of drug, which is an oral somatostatin analog. So we learned about sandostatin and lanreotide, which are one of the mainstay of treatments for somatostatin receptor positive metastatic neuroendocrine tumor. However, they're both injectable form of somatostatin analogs. And for the longest time, there was a need for an oral alternative, patients who don't like to be injected and don't want to come for monthly injections. So this particular study tested paltusotine, which is an oral somatostatin analog in carcinoid syndrome patients. We presented the data in NANETS in November. And it was an international phase 2 randomized study. We tested 2 different doses of paltusotine for patients who had either carcinoid syndrome diarrhea or carcinoid syndrome flushing. And what we found is that both flushing and diarrhea significantly improved after taking 8-week course of oral paltusotine. In fact, the improvement triggered within first 2 weeks itself and continued as long as patients stayed on the pill. So very encouraging results. And in this slide, you see the reason why the drug works is because it lowers the serotonin levels. So that's the proof of mechanism. The patients who stayed on the pills had sustained and durable suppression of serotonin levels. So again, one of the drugs that can be potentially used for carcinoid syndrome management, although it is currently under drug development, it's not commercially available at this point in time. But interesting developments. So to summarize, what are some of the treatments for metastatic well-defined neuroendocrine tumors, the typical atypical carcinoid? This is the NCCN consensus guidelines, and you can see patients who are somatostatin receptor positive, we often start with octreotide or lanreotide. In certain cases, if it's a very low volume, asymptomatic disease and low-grade disease, we may even decide to observe them closely and not start any treatment till the tumors are growing. Subsequent treatment options include everolimus based on NET Radiant-4, PRRT, although prospective randomized data is missing, but oftentimes you'd be able to get PRRT approved for our lung NET patients as long as they are somatostatin receptor positive. I highly advise and advocate for participation in Dr. Hope's trial, which is randomizing patients between Lutathera and everolimus in lung NETs patient. There are chemotherapy options with platinum-based chemotherapy and CAPE-10-based treatments. And last but not the least, clinical trials, very important. That's how we find newer breakthroughs, newer drugs. And most recent example of that success story is cabozantinib, where we have a positive trial which included lung NET patients, and that expands the treatment options for our lung NET patients. This is a small plug for a publication that we wrote summarizing how to manage well-differentiated neuroendocrine tumors of lung. Me, my colleague, Dr. Ramirez and Dr. Gupta from Vanderbilt and Alabama joined hands to write this nice summary about management of neuroendocrine tumors of lung origin. So feel free to check it out. Thank you.
Welcome back for our question and answer session. As a reminder to our audience, this question and answer session is for educational purposes only, does not substitute for medical advice. Please talk to your medical team with any concerns or questions about your individual care or treatment. We have over 30 questions. We're going to try to get to as many as possible on the topic of lung neuroendocrine cancers that are in the area of Dr. Chauhan's expertise, but we may not cover all the questions. Just so the audience knows, we don't necessarily address these questions in order that they were submitted, but instead in an order that makes sense. And We will address general questions only, and Dr. Chauhan will be answering the questions generally as well. He cannot provide specific feedback on your specific situation. So thank you, Dr. Chauhan, for an excellent presentation, well, two presentations that spans the wide range of lung neuroendocrine cancers. We're really excited to have you here. Thank you for attending to this special population and topic. And with that, let's get to our questions. Which is, if the NET tumor is found in the lung, how is it determined if this is a lung NET primary or if it originated from somewhere else?
Great question. The pathology is the key for sure. The pathologists have a way to differentiate different type of neuroendocrine tumors based on the looks, what we call morphology. So pancreatic neuroendocrine tumor might have a different pattern. Lung nets, for instance, they might have what they call salt and pepper chromatin. So one is looks. The other is certain immunohistochemistry stains. Now, certain stains or dyes that we often use for neuroendocrine cancers, they are expressed across the spectrum in lung nets, GI net, pancreas, like chromogranin would be present in everything, synaptophysin would be present. But certain like TTF1 in certain subgroups of neuroendocrine cancer of lung origin might be present in the lung. So those are some additional clues, especially for high-grade neuroendocrine cancers, that's the case. And also we have to factor in the imaging. If we have a big tumor in the colon or the pancreas, clearly it sounds more like a GI neuroendocrine cancer, as compared to we have a clearly defined thoracic primary on the PET scan or the CT scan. So we really have to piece together all this information, but the pathologist would give us the most important clue that looks like a thoracic typical carcinoid or atypical carcinoid.
Yeah, so the pathologist review is really key. Thank you for clarifying. This is another excellent question. Which lung neuroendocrine cancers are more likely to spread, and what characteristics make it more likely to spread?
Very challenging disease for that particular reason. Now, between the gradation, you've seen a neuroendocrine tumor of lung origin can be typical carcinoid, atypical carcinoid, those middle of the road tumors with unpredictable behavior, and the neuroendocrine carcinomas, the small and large cells. Now, in small and large cell neuroendocrine carcinoma, it's a very predictable behavior, very aggressive, and they often tend to spread early, metastasize. They can go to liver, adrenal gland, brain, bones. We often look at those areas. The typical carcinoid, very few of them metastasize. A lot of them are caught very early. That's why a lot of them would be cured with surgery alone. But they can certainly metastasize, occasionally to liver, and some other organs. Atypical carcinoma are very challenging. First of all, they're super rare. And the reason why they are atypical, they don't really follow a typical pattern. So I've personally had patients under my care who have presented with brain metastases or mets in the eyes and the retina and some completely weird locations, or skin or cutaneous mets. So you really need to have, keep your radars up based on individual symptoms or clinical manifestations. You might want to consider certain areas of scans to rule out metastases. But low-grade nets, unlikely to metastasize, and if they do, liver is probably going to be for distant metastases. For atypical, yes, liver, they can metastasize, and very rarely, I think in the literature, about 5% risk of brain mets for atypical or higher grade neuroendocrine. Now that risk increases quite a bit in large cell neuroendocrine cancer, about 10% risk of brain mets, and small cell, almost 30% risk of brain mets.
Yeah. Well, thank you for addressing the range too of what can happen. So you mentioned that it can spread to other areas. How would you know if a lung neuroendocrine cancer has spread to other areas? What symptoms should you look for?
Oftentimes, we don't rely on symptoms. That's why a patient who is early stage and is at risk of relapse, we depend on our scans or imaging for surveillance. Because many patients are caught asymptomatic, so we don't really fully rely on just symptoms alone. Clearly, if patient has headaches, blurry visions, intractable vomiting, just too much of nausea, vomiting, and projectile vomiting. Those are symptoms of raised intracranial pressure, so some sort of a tumor in the brain. So that will prompt me to do an MRI to rule out any concerns in the brain. If patient has bone mets, they will often have pain that is just not going away, and it's very specific location, unlike our musculoskeletal pain, achy joints. Unlike those, these bone mets pain, they'll be localized, they'll be fixed, they'll be always hurting at that particular spot. That'll trigger us to do an appropriate CT scan or MRI based on the location. So the symptoms would be individual and also organ specific, and the tumor volume specific. So a big bulky tumor might have more symptoms as compared to, but many patients are asymptomatic, and that's why we really surveil or follow patients based on the imaging. And the imaging, the frequency of it varies based on what type of neuroendocrine cancer are we surveilling. We don't want to overscan patients, right? So somebody with typical carcinoid stage 1 had a good surgery, we don't really want to scan them every 3 months or 6 months, just because the risk of relapse is very low as compared to small cell lung cancer, where the risk is very high. Even in early stage, I often surveil them with scans every 3 months. So it's not one size fit all. It's based on individual risk, staging, and what morphology, what type of neuroendocrine cancer we are surveilling.
Oh, thank you for that. And that actually touches on this question. So let's take this as a follow-up. How long should someone continue getting scans, I guess, particularly after surgery, to remove the lung neuroendocrine tumors, and which scan's ideal? I know, Dr. Chauhan, I've had some people say to me that their doctor, their provider, who may not be a NET expert, might stop scanning after a certain number of years. So is there a certain length of time you would recommend getting scans?
This is an area where we probably need more data and more research. One of the issues with typical and atypical carcinoid, these are rarer cancers, and we don't have data, high quality data looking at long-term follow-up. At best, we will have patients who've been followed for 5 years and then 10 years. Extremely few patients who've been followed with good quality scans and good quality data beyond that. Can these tumors come back several years later? Yes. I think providers like me who just do this or focus on neuroendocrine cancer, we have patients in our practice who had relapse disease after 15 year, 18 year, 20 year. However, those are extremely few cases. In my experience, most patients, if they really relapse, it's within 5 years to 5 to 10 years. For atypical carcinoid, it's within 5 years. Typical carcinoids, being a slow growing type of tumor, can go up to 10 years. Small cell lung cancer, within 2 years itself. If there is residual micrometastatic disease, it will manifest itself within 2 years itself if the cancer is back. So again, no one size fit all approach, but with typical carcinoid, the lifelong risk of relapse is so low, especially in early stage cancer, and cumulative risk of potential, too many scans, and these scans with CT scans oftentimes have iodine dyes, which are not good for kidneys, and radiation. So it becomes a risk benefit balance, right? So I would scan them from anywhere between 5 years for sure, and beyond 5 years based on individual risk patient factors. Some patients are very anxious and they rather like to know what's going on, and stage of the cancer. For stage 1, I would probably have the least concern for typical carcinoid, and I'd probably peel off scanning sooner than later. Atypical carcinoid, I am worried, especially stage 2, stage 3, with some lymph node involvement that they might relapse. I do like to watch them a little bit closer for 5 years and beyond. And I probably would stop scanning beyond 10 years for everybody. If they've met that time point, I think we are usually good.
Okay, so looking at about a decade in general. And you mentioned that sometimes there can be spread to the brain. Do you recommend a baseline MRI of the brain, as LACNETS can spread to the brain?
For small cell lung cancer, yes, it's actually standard of care. Every patient who's diagnosed with small cell lung cancer needs to get a baseline MRI, because almost 30% patients can have brain mets with small cell lung cancer. This risk of brain mets is very low for typical and atypical carcinoid. So it's not needed at baseline. And every patients do not need an MRI brain for typical carcinoid, especially unless there are concern, patient-specific concern. If there are headaches that cannot be explained by anything else, blurry vision, any of those symptoms, focal weakness or numbness or any neurological deficits, clearly we should investigate, but is not needed. And I would like to reassure majority of patients, I guess in this webinar, majority of patients probably belong to the well-differentiated neuroendocrine tumor category than typical atypical carcinoid. Brain mets is highly unusual. I do want to reassure you that that's not the typical presentation, and the risk is very low for brain involvement.
Thank you for the reassurance. This is an interesting question. There's been talk about increasing prevalence. What is thought to be the cause of the increasing prevalence of NET cancers?
It's $1 million question, and everybody from lung world to GI world is asking, because if you look at the incidence of neuroendocrine tumor, we see that there's a consistent and constant spike in the incidence every year by year. It sort of seems like going up, regardless whether we are dealing with GI or lung or pancreatic origin or neuroendocrine tumors. In fact, if you look at the breakdown, probably lung is showing the most spike in terms of increase in the incidence. We don't really know why. It's definitely better diagnosis. We scan a lot more people, a lot of incidental diagnosis, patients going into ER for pneumonia or some other chest issues. Sometimes patients have been caught to have typical carcinoid because they were getting an echocardiogram, and during the technician, when they were doing an echo, they saw like a mass in the chest, which prompted a CT scan. So a lot of asymptomatic patients are being diagnosed incidentally because we are doing a lot more scans. Our scans are also getting more sensitive. For example, dotatate PETs in these kind of scans, they're picking up smaller diseases. A lot is also due to awareness about this condition. Neuroendocrine tumors used to be not so well known, and hats off to patient advocacy groups and educational groups like yourself who are really championing and spreading the awareness about neuroendocrine cancer. So 10, 15 years back, very few doctors knew about it. Now a lot of doctors know about it, and diagnosis not getting brushed under the carpet. If somebody's diagnosed with neuroendocrine tumor, they are getting their due diligence. They're getting referral to an oncologist for proper staging workup. Our understanding of different neuroendocrine tumors has also evolved just in front of my eyes. The way the pathologists used to describe neuroendocrine tumors is also evolving, and that's because our understanding of these tumors are getting better. So I think we're just getting better in capturing the diagnosis. Is there an environmental factor to it that is responsible? That we are not sure yet. That's an area of study that we should study. If this risk or incidence continues to go up over next several years or decade, then clearly there is something beyond just better understanding and diagnosis that is causing these cancers to happen more frequently. And that is yet to be discovered, that is yet to be studied formally.
Related to that, someone submitted this question. The WHO did not set a classification of lung NETs based on Ki-67. What is your take on that? And if you could explain what this means as well.
So we've all heard of Ki-67. This is one of the immunohistochemistry biomarker that we use to classify or stratify the grades of the neuroendocrine tumor when it comes to gastroenteropancreatic neuroendocrine or GI origin neuroendocrine tumor. The lung pathology committee is distinct from GI. So we are trying to bring them together and kind of make it very seamless. But as of today, the pathology group for the lung are a separate group and the GI is separate. That's why you see subtle difference in the terminology, right? In lung, we say typical carcinoid, atypical carcinoid, and then large cell and small cell. In the GI world, we're kind of moving away from the carcinoid. We're kind of establishing grade 1, grade 2, grade 3, well differentiated, and then poorly differentiated. Because of those, differences, there's a different committee who define lung neuroendocrine cancers. They rely on mitotic index. to classify or grade thoracic neuroendocrine tumors. So Ki-67 is not how we classify or grade lung neuroendocrine cancers. However, in last iteration of WHO classification for lung, they do acknowledge growing role of assessing or evaluating Ki-67. In fact, they encourage pathologists to run Ki-67. And once we have more data and how it fits and how we can use this information in the lung world to further classify, I foresee in future iteration, we will use Ki-67 formally to classify thoracic neuroendocrine neoplasms as well. But right now, Ki-67 is encouraged to be investigated, but the classification is based on mitotic index. That's number of mitosis happening under per high power field. So they count those, and based on that, we classify.
Thank you for that thorough answer and explanation of that. How about DIPNEC? How is DIPNEC differentiated from multifocal pulmonary NET metastasis? And if you could also explain what DIPNEC is.
So get ready, Lisa. DIPNEC stands for diffuse idiopathic pulmonary neuroendocrine cell hyperplasia.
A mouthful.
It's a mouthful. So I like the word DIPNEC. It's easy. It is not very well understood entity. Okay, and primarily because it is very rare. Some people debate if it's even a neoplastic condition. Some people believe this is pre-neoplastic or sort of precursor, that this happens first and then may evolve into a lung net. So we are still kind of understanding what it means. However, there are certain differences between a bona fide typical carcinoid or lung net versus DIPNISH. The DIPNISH are oftentimes very small neuroendocrine tumorlets. Sometimes they can be large, and that's where the questions come, multifocal pulmonary net, but oftentimes they are under 5 millimeter. Sometimes they might not even invade the basement membrane. So pathologists usually would use these clues to say this is lung net versus DIPNISH based on the pattern, size, and location. However, we are uncovering that there could be larger tumorlets beyond 5 millimeter that will put them into actual lung net category. And then maybe there are, also another form of DIPNISH. My personal take is all of these are a spectrum, and they might not be a distinct entity that, DIPNISH is like day and night different than smaller lung nets. So I think it's a spectrum of disease. They're all of neuroendocrine origin. They all have the commonality of some common biomarker that stand for neuroendocrine biomarkers. And they just fall into different spectrums. So DIPNISH might be maybe very early or precursor, and then typical atypical carcinoids as it gets more aggressive or require more mutations. That's my hypothesis. I think we need to study more on these, these rarer subsets of lung nets.
We need more data. Thank you. Thank you for that. What about histamine secreting lung nets? What's the incidence of that?
Yes, very rare, extremely rare, in fact. Lung nets in general, majority of patients are non-functional. That means they don't secrete any hormones, they don't secrete any chemicals that will give additional symptoms. However, some lung nets can be functional, and some of those are usually carcinoid syndrome, where there's some secretion of serotonin. Some can have secretion of ACTH, so giving Cushing syndromes like picture. Certain lung nets can secrete bradykinins, giving symptoms of asthma-like symptoms, wheezing, bronchoconstriction, etc. It's extremely rarely that lung nets secrete a chemical called histamine, which is often linked to allergic responses and allergic conditions. And histamine reactions often you'll see rash, red discoloration of skin. There could be hives. There could be some swelling. If you've seen somebody get stung with bee or some sort of food allergies, that's a typical histamine sort of reaction. It can happen in lung nets, extremely rare though. I think it's so rare that I don't think I can even quote you a number, a reliable number that 1% or 2% lung nets would have histamine. So the diagnosis is very based on classic presentation. If patient has a documented history of lung neuroendocrine tumor and has a very typical history of histamine, one of the things we check for that is do dermatographia, right? So I'll take a blunt object like a key and I'll write something on patients, maybe on the opposite side of hand, and then give it a minute or so. And patients with elevated histamine issue, that area wherever I've drawn something would actually manifest itself. It'll look a lot clearer and it'll kind of swell up and become red. So that's called dermatographia, and that's how we differentiate. Somebody think that, oh, they have carcinoid flush, but it's rather a histamine problem, because you would not see that with elevated serotonin, the dermatographia. So those are some of the things, but the actual diagnosis based on the blood-based assays for histamines and other things.
Yeah, thank you for addressing that. Concerns about histamine does come up in the population, so thank you for that. So another topic and concept, you've mentioned that there is low or no SSTR, somatostatin receptor expression. So if there are low to no somatostatin expression, I guess why is that? And what does it mean? And then there's another question on here, what treatments might be appropriate, which I know you've talked about in your presentation.
This is one of the reasons why lung nets are a little bit more complex as compared to our GI or pancreatic nets, because the somatostatin receptor is not always present. Even if it is present, it might not be homogeneously present. That means it's not consistent. Some areas might have SSTR expression, others not. And then there are some neuroendocrine tumor patients, lung net patients, who won't have any SSTR anywhere. We often see that as an issue. So the first step we have to do is understand if we are dealing with SSTR positive patient or SSTR negative patient. So getting a dotatate PET is very helpful in understanding SSTR positive carcinoid versus SSTR negative one. Why it happens, I truly don't understand the biology of it. I don't think we understand it well, why certain lung nets are SSTR negative. And to give you a little bit depth of the problem, we don't really even have good animal models where we can study typical and atypical carcinoid. Unlike small cell lung cancer, we have a lot of really good models. We usually struggle in preclinical modeling, and that really impacts how we study these rare type of lung neuroendocrine cancers to understand or improve our understanding of why they develop, how they develop, why some patients have atypical and others have typical, and how do they evolve. So all of those questions are currently being investigated in different labs, people who focus on this type of rare cancers. Hopefully in near future we will know why some patients have SSTR expression and others don't. But for now, what is more important and practical thing for us to look at is we have to understand there are patients who won't have SSTR expression, and it's important to get a baseline SSTR status on each lung net patient so we can tailor our treatment. And based on if it's SSTR positive versus negative, our treatment choices would be very different. So SSTR positive patient, as you saw in the presentation, we may start with somatostatin analogs, then jump on to PRRT, as compared to SSTR negative, where there is no role of somatostatin analog or PRRT, and we might have to start off with everolimus, which is an mTOR inhibitor. And then we have a new fantastic addition to our field with cabozantinib that's also very effective in lung nets. So we have to really depend on drugs which don't depend on SSTR targeting for SSTR negative patients.
So what it means, what you're saying, is that it helps guide the treatment decisions and treatment options.
Yeah. Absolutely.
And if I could ask a follow-up with that, does this SSTR somatostatin receptor expression change? Is it possible to change where you either can later on have expression or lose expression?
That's a great question, Lisa. And it can happen. We always have to keep that as a possibility. In GI world, my experience has that we don't see a major shift. So if somebody had a lot of SSTR expression, like a mid-gut carcinoid or a small bowel or pancreatic net, it usually would maintain that degree of expression unless there is a very small number of patients will have grade migration, becomes more aggressive or de-differentiated and loses that expression, becomes higher grade. That can also happen, but that's not the rule. That's not the common situation. In lung nets, I have seen the change in SSTR expression actually more frequently than GI or gastroenteropancreatic. In fact, with atypical lung nets, atypical carcinoids, where it's already heterogeneous somatostatin receptor expression to begin with, that means there's a mix and match. Some areas are SSTR positive, others are negative. Oftentimes, what happens is if we end up treating a patient with atypical carcinoid or a little bit higher grade variety cancer in the lung with some sort of chemotherapy, and in future what we'll see is that that higher grade component got treated, and now we have the residual disease which is more SSTR avid, and then we can maybe use some of our SSTR directed therapies. So I often try to reevaluate SSTR expression in future, especially if there's been a significant change or there is concern that certain areas are growing faster, but other areas are growing very slow. And so if there is a discordant biology or the way the tumor is behaving, it's important to understand how the SSTR expression is changing. That might give you some clue how aggressive or less aggressive you need to be in future progressions. So that can happen. I would definitely advise to, at some point, look into SSTR expression down the road after a few lines of progression.
Possibly revisit that. So here's another excellent question. How is lung neuroendocrine cancer that is primary lung and spreads to liver and bones, how is it treated differently from other neuroendocrine cancers that have a different primary origin, like GI and pancreas?
Great question. So a lung neuroendocrine cancer going to liver or bones is a different cancer. It's still a lung neuroendocrine cancer in the bone as compared to the pancreas neuroendocrine tumor into the bone. So subtle differences. Like I mentioned, a pancreas, for example, or a small bowel neuroendocrine tumor is almost always somatostatin receptor positive. Okay, unless we are dealing with a very high grade 3s, it's almost always SSTR positive. So our treatments are pretty well set. We'll start with sandostatin, lenalidomide, and then jump on to maybe PRRT, and we now have options like for pancreatic net, cabozantinib, CAPTEM, mTOR inhibitor, for midgut, mTOR inhibitor, cabozantinib. So we have these options. It's kind of pretty much set. For systemic therapies, of course, some patients may benefit from liver-directed therapy and surgery and other things. When it comes to the lung nets, so lung nets with liver metastasis, it'll still behave like a lung net. So what that means is it might not express somatostatin receptors. So you might have disease in the liver, but it's not lighting up on your dotatate PET. So all these SSAs and PRTs, these options will be out of window for us, and we'll have to look for non-SSTR directed therapies, okay? Those are some subtle differences. However, there are some commonalities. If it is a well-differentiated neuroendocrine tumor, like a typical atypical carcinoid, may not express somatostatin receptor, but that doesn't mean it's going to be very aggressive. It's like going to behave like small cell lung cancer. So I oftentimes also do FDG PET for these cancers if they are SSTR negative. And if they are not super hot on FDG PET, that means they're not hypermetabolic. I may often treat them like with other treatments which work very well in well-differentiated neuroendocrine tumors like Afinitor, mTOR inhibitor, cabozantinib. However, if it's an aggressive variety of SSTR negative disease that is growing very rapidly, patient symptomatic, and is lighting up very bright on FDG PET, I know that this is not like your typical carcinoid. This is kind of being very aggressive and doesn't have somatostatin receptor. So I'll often use chemotherapy. CAPTEM is one of them. If it's even higher grade, we might even use platinum-based chemotherapy. So it's a lot more nuanced, especially when it comes to atypical carcinoid. For typical carcinoid, SSTR expression is going to determine initial treatment choices. So those are the differences. So despite liver being one of the common sites of metastasis, the origin does play into how the tumors will behave and what treatments we will choose.
Yeah, that's really helpful. And, on the flip side, there was someone who submitted this question. So if they have a primary net, say in the duodenum, anywhere in the GI, and it spreads to liver and bones, how common is it to spread to the lung? I think that's maybe a concern, if you could address that.
Right.
Does it eventually spread, or
It,
is this,
it's very rare. It's not the commonest site, for sure. The commonest site for your GI neuroendocrine tumors by far would be liver, lymph nodes, and bones. For a GI origin neuroendocrine tumor to spread into lung, it's very rare. Can it happen? Yes, but it's not very common. In our clinics, patients, in our program, we just see neuroendocrine cancers, seeing hundreds of cases a year. We've probably seen all sort of permutation combination, but that doesn't mean that happens all the time, right? So it's very rare. However, because, as I mentioned, bone is one of the top 3 sites we'd like to go to, those bones could be in the thoracic cavity, like ribs or spine. So we always surveil for chest as well. So if somebody has duodenal neuroendocrine tumor, we just don't do abdominal CT and we call it a day. We also want to know, has it spread in the chest cavity? I'm less concerned about it going to the actual lung, but outside the lung, the lymph node areas, the bones, the ribs, and the spine. It can happen in the lung, but not a common presentation.
Thank you. And this question speaks to what about mixed presentation? So if someone's primary lung tumor shows uptake on a somatostatin receptor PET, but the metastases don't show uptake, and the biopsy of the liver shows a higher grade Ki67 30% small cell poorly differentiated tumor, can the patient benefit from a somatostatin injections?
So pathology is the king. I will go by the pathological diagnosis. So pathologists say small cell poorly differentiated neuroendocrine carcinoma. We have a very distinct way of treating them. These are the NECs, the second half of the talk, and very aggressive cancers, rapid doubling time, and we often have to use chemotherapy. And now we have some newer immunotherapy options for them with DLL3 BiTE and certain other immunotherapy drugs, but very different cancer than a typical or atypical carcinoid. So usually we reserve SSA to a well-differentiated neuroendocrine tumor. Those drugs are cytostatic at best. That means it slows down the cancer, is not strong enough to cause tumor shrinkage. So for a small cell and poorly differentiated neuroendocrine carcinoma, SSA injection, I don't think are impactful and would be effective enough. And we don't really have good quality data to support that. We don't want to overtreat, because these drugs, even if they're safe, they're not chemotherapies, the SSAs, but they still have financial toxicity. You still have to get once a month injection. So in absence of clear data that they help patients live longer or help stabilize the cancer longer, I would refrain from using SSA for small cell carcinoma, even if it's an SSTR positive. However, having said that, I'd like to take this opportunity to maybe cue in. There are some SSTR related radiopharmaceutical drugs like Lutathera. So SS may have potential role in treating small cell carcinoma, especially those are SSTR positive, because those treatments are more effective. They are radiation based treatments, so there might be a role, and it's currently being investigated in small cell poorly differentiated neuroendocrine carcinoma using different type of radiopharmaceutical targeting SSTR. Also a curious interesting point, the Ki67 is about 30% small cell, which is usually not the case. Usually the small cell histology is much higher Ki67, so it could be one of those things where you want to get pathology confirmed and make sure that that's what it is. Usually I would see 50, 60, 70, oftentimes even 90% plus Ki67 for a small cell type of morphology.
Yeah, and good point. Thank you for raising that there are other treatment options for somatostatin receptor positive tumors. If there's tumors that light up and tumors that don't, are radiopharmaceuticals like PRT, is that still an option if some tumors light up and some don't?
Yeah, it's under the research protocol. So I would not advocate that, oh, we start doing off-label Lutathera, because we don't really know, one, safety, can be safely done, second, how much effective it is, because again, PRRT drugs are not completely without side effects. They're relatively well tolerated in most patients, but they're not without side effects. So a golden rule is we need to first confirm they benefit our patients. So the patients have access to clinical trials testing these radiopharmaceuticals and you are a good fit, I would highly encourage you to look into it. But I think a lot of drug development for NECs, the small cell and protein differentiators, is kind of leaning more towards DLL3 targeted therapies, especially these newer immunotherapies. So that's where we are seeing a lot more exciting data and promising data, which we also kind of thrown some light on the presentation. I would highly advise to consider those studies if you have small cell carcinoma, and those work regardless of SSTR status, right? So that's good. But right now, PRRT against SSTR in high grades or NEC is not ready for prime time. It's in first in human studies, and you don't want to use these drugs till we have better data, till we know if it helps.
Yeah, thank you for that. And for those who are looking for information on these trials, we do have them in our clinical trial guide, and Dr. Aman Chauhan has short little videos on that. So I do want to take another question in the NEC realm, and I know for some of you who did not yet watch the session B that highlights the NEC, you can go back and watch that on our website and YouTube channel. And I know you discussed the treatment sequencing for lung NEC on that video. But Dr. Chauhan, can FOLFIRI also work in lung NEC?
Another great question. NECs of lung, especially outside small cell lung cancer, have very few options. Large cell neuroendocrine carcinoma of lung has very few options. We often treat them like small cell lung cancer. And in small cell lung cancer, we use platinum-based chemo plus immuno as a frontline. After that, in the current era, we are going to be using tarlatamab or clinical trials with the L3 BiTE antibodies in the second line space. For third line, we'll often use lurbinectedin or topotecan. Many people don't like topotecan, including myself, so I often use irinotecan. So in the lung space, we might use irinotecan by itself, and that's because that's how traditionally small cell lung cancer patients have been treated. FOLFIRI is not a very common regimen for lung NECs. It's very, very commonly used for GI origin NECs. This regimen comes from colon cancer, very, very commonly used. So I often use FOLFIRI for my extra thoracic neuroendocrine cancers. That means small cell or large cell neuroendocrine cancer of cervix or ovaries or gallbladder or colon or pancreas. Very, very commonly used. But for the lung NECs, we often sort of follow the small cell lung cancer paradigms, and we might have already used irinotecan because we use that, or topotecan. So we might not have the opportunity to use FOLFIRI. Having said that, anecdotally, where I've used it, I think it does work. A lot of these cytotoxic chemotherapies are not very tumor specific. There is a lot of cross activity. Even in FOLFIRI, as I said, one of the active agent is irinotecan, which is also used in small cell lung cancer or lung NEC. So that's one of the drugs there anyways. So FOLFIRI can work in lung NECs, but we do have other options that we often fall back on small cell lung cancer treatments for lung NECs.
Thank you for that. And you, meanwhile, answered another question that someone asked if NEC lung cancer acts like small cell lung cancer. So thank you for that. We're just going to take two more questions. There's actually two questions on radiation. Is radiation effective on lung NET? And if so, when is it recommended? There was someone else who submitted a question about possibly using radiation instead of surgery, and if that's safer for tumors that are close to the heart.
For an early stage lung NET, that means stage 1, 2, or 3, it's advised to do surgery, because by doing surgery, we can definitely say it's all out, it's gone. We can also do a good lymph node sampling that way. However, there are times where the risk of surgery might outweigh the potential benefit. For these, especially typical carcinoid, low-grade neuroendocrine tumors, patients may live for several years without probably even anything, right? That's just the natural history of disease. So if you have somebody at 90 years old, they might take that calculated risk that surgery might have higher risk, especially if there are comorbidities, heart conditions, diabetes, kidney issues, etc. So sometimes we don't need to take the drastic side of surgery. However, surgery is curative and is the standard treatment for somebody who's otherwise fit and is okay to go for surgery, understands the risk. But those patients who are not okay with surgery or are not fit enough to get surgery, or the risk benefit does not align, because of either age or comorbidities, then we have two options. One, to just not do anything and just observe and let it play out, see how tumors will behave. Some lung nets, especially typical carcinoid, may be so slow growing, it might take several years before they start growing or start having problems. So that's one strategy. The other strategy is to do radiation. I'm fairly impressed with radiation, especially the newer type of radiation like SPRT, where you don't really have to give weeks of radiation. It's just 4 or 5 or 6 days of radiation and you're done. It's highly focused, high intensity radiation in that area. And what that will do is it might not make the cancer disappear. You might still have that tumor that you will see. It might shrink it a bit, but it certainly slows it down. It certainly controls it for a really good amount of time. That is one of my concerns with keeping the tumor in the lung intact, because if it grows, eventually it will give shortness of breath, coughing, and some of the quality of life limiting symptoms. Again, if it's very tiny, may not be the issue, but if it's a large enough tumor closer to your main airways, down the road it might cause more trouble. And if you're not ready for surgery now, it might even be less likely in the future. So if you can radiate that sometimes can arrest the growth of that tumor, or sometimes even eliminate the tumor, but you'll still see that residual scar tissue left over. But we technically don't say we cured somebody after radiation. You still have to be monitored, make sure that doesn't come back. So there is definitely a role for radiation in the right patient, and I often use it in the right patient. I've had good experience. Don't expect drastic shrinkage like NECs. In NETs, typical, atypical, you will see some stability or mild shrinkage, but you will see that there'll be that residual tumor there, might be dead or alive, but you'll have to keep an eye on it.
Yeah, thank you for that thorough explanation. And for those who are interested in learning more about radiation and what you brought up, SBRT, our podcast episode that will be released later this month is actually on this topic. So we'll end with this last question. I know there's a lot of developments. I know you have a lot of passion and you're doing a lot of work in this area. So we thank you for that. But what new or upcoming developments are you most excited or optimistic about?
I think right off the bat, the biggest news, the tangible development that we can use right now for our typical and atypical lung carcinoma patient is cabozantinib. Especially for SSTR negative patients, for well-differentiated NET patients in lung, we had very few options. After Afinitor, we didn't really have much to offer. So it's really good to see that we have another targeted therapy that can be used for our thoracic neuroendocrine cancer patients. It's not FDA approved yet, but the data is very provocative. It's a positive study, and I'm really hoping that we have an approval so that we can have easy access to this drug for all NET patients, including lung NETs. As far as the high-grade NEC is concerned, I think the biggest breakthrough in the recent past is the DLL3 targeted BiTE antibodies. We already have tarlatamab, which is FDA approved for small cell lung cancer. But there are now next generation of trials, ourselves at University of Miami, we are combining these DLL3 BiTEs with frontline chemoimmunotherapies or second-line lurbinectedin and topotecan. So once you find an effective treatment, you try to maybe make it even better by combining with other active agents. So I'm very excited about how this DLL3 targeting landscape is evolving. And of course, we need newer drugs as well and more targets. So stay tuned. There are a lot more exciting drugs in the pipeline with radiopharmaceutical targeting of SSTR in these high grades, with the DLL3 targeting of radiopharmaceuticals targeting those DLL3 in high grades. So there's a lot happening in high grades, and I think it was much needed. We had basically a stagnation of ideas or successes in high-grade neuroendocrine cancer for a really long period of time, but things have started finally moving along, and so very, very excited for those advances.
And thank you for being part of pushing for those advances and making those things happen, because we need that. We need people like you who are the difference makers, who are committed to this field and to helping the NET patient community. So really, on behalf of the entire NET patient community, we really want to thank you for all your hard work, all you do to help people live longer and mostly live better. So thank you for all you do.
Thank you so much, Lisa. Thank you so much for this opportunity and great questions. And thank you, the audience and viewers, to tuning in. This is a great resource. I'll give a shout out to the whole LACNETS team for providing these wonderful webinars, lectures, and a lot of important educational resources on their website. So please check them out. And great to be here again. Thank you, Lisa.
Thank you. And I'm going to send it back to Heather in the studio.
Thank you again, Dr. Chauhan, for your truly comprehensive presentation and for answering specific questions on lung neuroendocrine cancer. We appreciate our supporters Novartis, Ipsen, Crinetics, Curium, ITM, and Exelixis. Educational programs like today's are also made possible by donors like you. Please consider making a donation today at lacnets.org/donate. And through the end of the year, your donations will be matched. And a special thank you to our technical director, Rich Tamayo from TVP Live, for this high-quality video production. Again, today's presentation and Q&A session have been recorded and can be viewed on our website, video library, and YouTube channel shortly after this broadcast. If you registered for today's webinar, you may receive a survey via email. We would greatly appreciate you completing this survey, as it helps us improve our content and with fundraising efforts. Again, follow us on social media to stay up to date with our upcoming events. Our handle is @LACNETS. And now back to Lisa.
Thank you, Heather. LACNETS is a community of support and resources. We recognize that you are more than your disease, and we aim to support you as a whole person. To this end, we offer many resources and programs. Find out more on our website, lacnets.org. LACNETS has a monthly podcast featuring experts who answer the top 10 questions in their field. Go to our LACNETS podcast page to check out the episode transcript, resources, and the 10 questions we asked the expert. Thanks again for joining us for today's educational event. Goodbye, and see you at our next event.